Hello, I am Dr. Kang from Department of Urology, Korea University Hospital, Seoul, Korea. First of all, it is my great honor to have a chance to talk about our paper, Standardized Analysis of Complications after Robot-assisted Radical Cystectomy, Korea University Hospital Experience. Open radical cystectomy is considered as a gold standard treatment for patients with invasive bladder cancer and refractory high-risk non-invasive bladder cancer. Despite improvement in surgical technique, open radical cystectomy still remains a morbid operation with a substantial complication rate. Recently, interest in robot-assisted radical cystectomy, or RARC, has increased for the purpose of reducing the morbidity and complication. However, the result of the researches about the complication rate of RARC are highly variable. The causes of these highly variable results are from that the methodology reporting the complication rate was non-standardized, and these studies were done by multiple surgeons in multiple institutions. Therefore, in this paper, we aim to analyze the complications of RARC by a single surgeon at a tertiary referral center with a standardized methodology. Here, I would like to introduce Dr. Pyun, who is the first author in this study. He will briefly summarize the study method and result.
Hello, I'm Dr. Pyun, a resident at Korea University Hospital. I'm going to present the material, methods, and the results of our study. We reviewed the prospectively maintained database of 52 patients who underwent robot-assisted radical cystectomy to manage bladder cancer by a single surgeon. The demographic data and peri-operative outcome in patients who underwent ECUD or ICUD were compared as well. The mean age was 63.3 years old. 13 patients underwent laparoscopic adhesional lysis due to the prior abdominal surgery. Mean overall operating time was 496 minutes, and mean estimated blood loss was 247 milliliters. In comparison with the ECUD group, mean overall operating time for the ICUD group was prolonged, but mean EBL was low. 27 patients had an ileal conduit and 21 had an orthotopic nerve bladder. 4 patients had an ureteral cutaneous stomy. The mean number of lymph nodes harvested was 30.5, especially in extended pelvic lymph node dissection. In the case of extended lymph node dissection, and the mean number of lymph nodes harvested were more in the ICUD group. All the complications within 90 days of surgery were recorded and graded according to an established 5-grade Cleveland classification. 50% of patients experienced at least one complication of any grade within 90 days of surgery, and 40.4% of patients experienced a major complication. The incidence of minor complications for patients in the ECUD group was higher than patients in the ICUD group. There was a significant difference in the physiologic test. Complications were grouped in a system-based category. 50 complications occurred in 52 patients. 25% of patients required blood transfusion. Wound dehiscence, anastomotic leakage, urinary tract obstruction, mechanical obstruction, and thromboembolism were occurred as major complications from 11 patients. 5 patients needed a wound revision due to wound dehiscence. All of them underwent a RARC with ECUD method. Among them, the 3 patients underwent wound closure, which was performed under general anesthesia, so categorized as a major complication. Anastomotic leakage occurred in 4 patients. Urinary tract obstruction occurred in 3 patients. and vascular thromboembolic event occurred in 2 patients. One patient developed mechanical obstruction. Univariable and multivariable logistic regression were used to predict risk factor of complications. Regarding predictor of total complications, EBL was a significant negative predictor on univariable analysis, and EBL and operate time were significant negative predictor on multivariable analysis. As predictor of major complications, EBL was significant in predicting a complication, but as predictors of minor complications, EBL, operate time, method of urinary diversion were significant negative predictors on multivariable analysis, while EBL, method of urinary diversion were a negative predictor on univariable analysis.
Thank you, Dr. Pyun. Standardized reporting of post-operative complication is vital for assessing innovative surgical technique, informed patient counseling, treatment planning, and clinical trial design. In this paper, we try to analyze the complication after RARC using a standardized reporting methodology by a single surgeon at a single center. Our result shows that a total complication rate was 50% and major complication rate was 21% within 90 days of surgery. When we analyzed the complication rate systematically, hematology complications such as transfusion rate were the most common and infectious complications were the second most common complication. From the above results, our study also shows that complication rate after RARC is still considerable, while comparable to those of other RARC series. In our study, the rate of complications in between the urinary diversion method were compared. The minor complication rate of extracorporeal urinary diversion was higher than those of intracorporeal urinary diversion group. Extracorporeal urinary diversion was a significant predicting factor of minor complication on both univariate and multivariate analysis. Our study had limitations. At first, our study was non-comparative, non-randomized study with open radical cystectomy, and therefore may have contained selection bias. Secondly, the sample size was relatively small, which limits the statistical power of the analysis. Thirdly, because the learning curve varies according to the surgeon's technique, supporting data from other surgeons with longer-term follow-up result will be necessary. Thank you for your attention.